I gotta say, it's a little bit ironic that I would be. This is what I said yesterday, right? What was I talking about yesterday? I said that I've never ordered a BNP because we don't have one at our hospital. A little bit ironic also that I would be talking about chest CT for chest pain evaluation. Same sort of situation. I mean, our CAT scanner, I would tell you that it's from World War II, only that they didn't have CAT scanners back then. They were only invented in like the 70s. But we have. I remember I was doing some research for a paper on subarachnoid hemorrhage that I was doing, and I wanted to find out the exact details about our CAT scanner. So, you know, is it a 4-channel? Is it an 8-channel? Is it a 16-channel? And I went up to the CT tech and I said, so how many channels we got on our scanner there? And he's like, channels? He's like, you know, he didn't know what I was talking about. Anyway, it didn't have any channels, he said. But it's pretty old. It's a nose picker 5000 or something like that. You guys got one of those? Anyone using pickers? Anyway, we will be eventually getting new scanners at our new place, and we'll be getting these fancy scanners that we're talking about in this paper, in this section here. Anyway, let's just remember Diane was talking yesterday about low-risk chest pain. This is in relation to low-risk chest pain, this whole business about doing CTs of the chest. It's also in relation to the new concept of the triple scan, or the triple threat, the triple rule out, where you're trying to rule out PE dissection and coronary artery disease on the same scan. That's what this is all about. It's about using high-resolution CT. Just to remind you of the numbers that we are talking about, the most recent time that we looked at how much we're missing in terms of acute coronary syndromes and MI was the Pope study in about 1991, and there was a 4% miss rate. So we probably miss about 3 to 4% of MIs and acute coronary syndromes, maybe 1 to 2% of acute coronary syndrome, and another 1 to 2% of actual MIs. So it's pretty good. How do we get that lower? Just to digress for a second, why is it this is so difficult? And why is it that Diane was saying yesterday, no matter what, you're going to miss these things? It just has to do with disease prevalence. There are certain things in emergency medicine where we're really not allowed to miss them. Examples would include a C-spine fracture or a subarachnoid hemorrhage. Those are both relatively uncommon things, and the threshold to miss them is widely considered to be 0. And it's a very achievable thing. If you have a sensitivity, and we're going to talk a little bit about sensitivity and specificity whenever we're talking about picking up uncommon things, we have to talk about those test characteristics. If you have a sensitivity of a test that's very, very high and a disease that's fairly rare, you're not going to miss many of them. So just to think of ballpark figures of what the sensitivity would need to be to have an instrument for x-raying the neck to not miss C-spine fractures, the nexus rule is 99.6% sensitive. If you have a 99.6% sensitive rule, and you apply it to a population that is going to have that disease that you're looking for very rarely, in the case of C-spine fracture, about 2% of the time in a major trauma, it's okay. You know, you're not, and they do the calculations. How long would you have to practice to miss one? Well, in the case of the nexus rule, you'd have to practice several careers worth to miss one. It's not the case with acute coronary syndrome. Everyone dies of heart attacks. That's the commonest cause of death, cancer and heart attacks, right? Those are the 2 most common causes of death. And it's just not feasible. Even if you had an instrument that was 99.6% sensitive like Nexus, it would still, because of the prevalence of the disease, miss a whole bunch. And that's why we keep saying you're going to miss it. What's an acceptable miss rate? Well, to a lot of doctors and to a lot of ED directors, it's still 0. But it's just not tenable. It's not possible when you have something that's so common. You're going to miss things. What do the lawyers think it is? They probably think it's 0 too, right? But we have to really, I think, start getting accustomed to the fact that the numbers, you know, it's kind of like Hillary Clinton at the end of the election, right? I mean, you know, the numbers just aren't ever going to add up for us to not miss these things. But we're going to try, and we keep trying. But when you start looking at the tests that we're discussing, whether they're the CTs or the nuclear medicine studies or the EKG stress test, none of them have numbers even nearing 99%, let alone 99.6. And so it's going to be really hard to get there. One of the problems with, what are the problems with acute coronary syndromes is that we don't really have a way to directly measure the actual disease that we're looking for. Remember what happened to Tim Russert a few weeks ago? What was it, 2 weeks ago Tim Russert died? Okay, and remember, and it was a horrible tragedy. And one of the first things that came up, they interviewed his cardiologist, I don't know if it was his personal physician, they interviewed him on TV, and they were talking about how he had just had a stress test. It's like he just had a normal stress test, and yet he collapsed dead shortly thereafter. Why does that happen? What's that?
Because of the stress test.
Yeah. Yeah.
People know the big one's on the way, and that's why they go for the stress test.
You mean people that are going for stress tests self-select themselves? Yeah. The thing is that acute coronary syndrome is a process where you have an unstable plaque, it ruptures, and then you have an aggregation of platelets and then clot to that. And none of the tests that we talk about, right, whether it's the EKGs or whether it's the nuclear medicine studies or the treadmills, none of those actually look at that. They're not looking for an unstable plaque. If we were actually looking for an unstable plaque and we could say we looked and we don't see it, then that might make more sense. For everything else is a surrogate marker. And most of the tests that we're looking for actually, or that we do, are looking for fixed lesions, right? So if you get on a treadmill test and you exercise, and then at a certain point you start getting ST segment depressions, chest pain, or hypotension, those are the signs of a positive stress test. What does that mean? It means that you have exercised to you've stressed that stenosis. That stenosis is no longer able to supply blood commensurate with what you're using. But that's a fixed lesion that we're looking for in that case. Well, it's the same thing for a dobutamine stress test with an echocardiogram, right? You're stressing the heart and trying to find a threshold by which you can no longer provide flow into a certain area, and then the wall motion in that area of the heart when you're doing the echo will be slowed down. Is that looking for an unstable plaque? No, that's also looking for a fixed stenosis. To be honest, it really is just a coincidence that when people have positive stress tests, either by exercise or echo or SESTA, maybe any of the things that you guys are using, it's just a coincidence that the people that have negative tests of those particular provocative tests are less likely to drop dead in the next 30 days. It's not because you're directly looking for an unstable plaque. And that's something that we really didn't, I think, have a grasp of until fairly recently, until we started to really get into the actual anatomic reality of what was happening inside a vessel. You can do a cath and have a negative cath and then go on to drop dead of a heart attack as well. And we talked about that a couple of days ago, didn't we? You have a completely clean cath and you can drop dead. Why is that? Again, because the cath is just looking for fixed stenoses. The cath can't tell if his plaque is unstable either. And so it's this really big conundrum. And I think that probably the med students are learning this right now, but we didn't learn it like this in med school. You know, this wasn't really understood in this way. And I don't think that a lot of doctors that are out in practice still have a grasp for what they're actually looking for on a stress test, and they don't necessarily realize how indirect a measure it is of what they're really looking for. So anyway, what would make a cath better, because a cath just looks on the inside of a lumen, right? It just looks to see what's inside the lumen, would be if the cath could actually look on the wall of the vessel to see what kind of plaque was there and to see maybe if it was unstable. And they've begun to do that. I don't know if you've heard about this, but they have now intracoronary ultrasound. And so if you do a cath and you attach a little ultrasound transducer to the inside of the probe, to the inside of the tip of the cath, you can actually start looking outside at the vessels to see what the consistency of the narrowings are. That's really interesting. Now we're starting to get onto it. Obviously, it doesn't sound very practical. I don't know when the last time you sent someone up for a cath with an ultrasound was. It's an experimental thing, really. But now we're really starting to get to the pathophysiology. And we're really, for the first time, the technology is able to actually look for what we're looking for. The other option, if you don't want to do something so invasive, is if you were to have a very, very high resolution CT, so high in resolution that it could see into the walls of the arteries. And that's what that's what the buzz is about this high-res CT, and that's what we're looking for. Mel Herbert, my colleague and friend who wrote this chapter, goes into a long discussion on the first page. Actually, we get obsessed with different things at various times, Mel and I do. In this particular instance, he got obsessed with CT scanning. He's got facts and figures about the history. He's got a little table there about the different generations of CT scan. I don't think it's necessary for everyone to be as obsessed about it as he was. You might be interested to know that the electron beam CT that you've probably heard about for people to check their calcium scores is a dinosaur at this point in time. They're very expensive to make, and there's only about 100 of them in the United States, and they're going to stop. They're not making them anymore. Instead, they're going with the third generation scanners with multiple detectors. And so if you see a patient that's had a calcium score done, one of these super sophisticated cardiac CTs, in most cases, it's been done on a third generation scanner with a 64 multi-row detector. It's not important to know exactly what makes it a third generation. It just has to do with the way the image is acquired, the fact that the detector and the table move at the same time, that type of thing. And that's not really important to know about. What's that? Oh, sorry. Okay, the other thing that happens is that these are gated studies. Right? So that, remember the MUGA scans that we used to do? We don't see those much anymore. But the gated study means that it's timed to the EKG so that the image is acquired when the heart is stillest in diastole, so that they can get a good image. It's not blurry. That's why it's so important for these scanners to have as many detectors as possible, to go as fast as possible, and to be gated with as low as possible a heart rate, and hence the beta blockers that we're often asked to give when we're acquiring these images. And the patient's also asked to hold their breath, right? Which is always funny when you're ruling out PE in the patient with COPD, they're asking to hold their breath for half a minute, and they're like, yeah, right. Anyway, there are two ways to do, just in terms of the technique, to review the technique, there are two things here. There's a non-contrast and a contrast scan. If you have one of these 64-channel third-generation spiral CTs, and you do an image without contrast, you're looking for calcium. And calcium is a marker for coronary artery disease. If you have no calcium at all, it's very unlikely that you have, is everything okay? You cool? We have some sort of, you want to see if it's a recording or something, or? It's cool? Sorry. You want to see if there's calcium there as a marker of coronary artery disease, basically. So if you've had friends go to and I'm nervous, I probably should, I don't know. My wife would like me to do that. Go and see if I have the calcifications and stuff like that, but I don't know what I would do with it. But if you've had friends go for one of these scans of an executive physical, that type of thing, that's probably what they've had, is a non-con cardiac calcium score done. Then the next stage, though, where it gets a little more interesting, is when they put in the dye, you get the contrast dye, and then you're actually doing an angiogram. So you have a combination of one scan that shows you how much calcium is there, and then the next scan actually gives you a coronary angiogram. There are still a lot of technical issues with this, and that's why this chapter is more of an informational, interesting thing rather than a core curriculum thing, because this is really not something that's a standard of practice yet. We're still working on it, but it's interesting and it's exciting, and it's a stimulating topic, really. At this point in time, 25, 30, 35% of the scans that they do, even at the best centers, even at Cedars-Sinai and places where they're really pushing the envelope with this, the images are inadequate. When they try to get these, there's just too many things that cause artifact, and there's too many things that can go wrong. And an angiogram, a conventional angiogram, as you know, is pretty good, and it's not fraught with that same degree of difficulty. One of the other problems that we encounter with the cardiac CT is if there's too much calcification, if there's so much calcium there, the angiogram part becomes useless because it's all scatter artifact, just like you see whenever there's calcification or bone or metal on a CT, you get scatter from the calcium. So too much calcium might mean that the patient just has a lot of calcium. It might not mean that they have very bad unstable plaques. It's hard to tell. And then when you do the angio, it's all sort of dog meat. You can't see anything. So that's just an unfortunate limitation of the scan. The calcium score above a certain number, the radiologist will say, sorry, this can't be really interpreted. What we really need, and what we don't have at this point, is a study to show us if this is a good thing to use in our workup of chest pain patients. Obviously, it's not for the high-risk patients. If they come into the ER with a STEMI or a non-STEMI, these are people that are going to be dispositioned. You might be giving them lytics, CCU disposition, that type of thing. Probably not even for the moderate probability people, who are going to probably admit as well. But for the low-risk people, this is when this is probably going to come into play. What we really need is a study that incorporates this, using this. Maybe you'll do an EKG and a troponin, maybe 2 troponins, and then you'll do this study versus a strategy where you're not using cardiac CT. That's the kind of study we need. Now, it's going to have to be a pretty big study because, remember, we're looking for a low incidence of disease. We're already really good at this. We're already very good at this, a lot better than we used to be. We're only missing about 2% or less of MIs. And so we're going to have thousands and thousands of patients in a study to show whether this type of a tool is going to be helpful to us. The other thing that's really difficult about this is that what equipment are we going to use for this study? Whose brand? How many channels? It's a moving target. By the time we get the study started, already 6 months into enrollment, there's going to be much better equipment that other people are going to want to use. And so that might be one of the reasons why we haven't actually, and as far as I'm aware, there isn't a good study like this going on. So what we have instead, unfortunately, are a lot of rinky-dink, piddly studies with 90 or 100 patients, and it's very hard to make any conclusions about it because of the nature of this beast, right? Remember we were talking about it a couple of days ago. Some studies with 100 patients are wonderful, but in the case where we're looking for things that where we've already got a low-risk population and we want to further perfect that, we're looking for subdivisions of 2% or 1%, we're going to need thousands of patients.
Who's interpreting it? Is it cardiology or radiology?
The question is, who's interpreting these studies? Is it cardiology or radiology? And the answer generally is radiologists are interpreting them. Yeah, and so the comment, and the comment is a good one, which is there's some turf battle issues that would probably be involved, and it might be not a great thing for the cardiologist if they were to lose all their cash in lieu of this. Okay, so just to, let's talk about I'll take one more question and then we'll go through the abstracts quickly and maybe we'll have some more time. Okay, 2 questions at the back and then the second one. How much radiation we're going to get to in a minute, and then, oh, good, great minds think alike, and we've got that. It's in a couple of these abstracts coming up. Abstracts number 1 to 3 are initial studies looking at the test characteristics of the cardiac CT. They're not emergency department studies. They're in the outpatient setting. They show basically that the studies have a sensitivity of 90% for a 50% stenotic lesion. What does that mean? What does that mean? What does it mean, a 50% lesion? I don't know what it means. I used to at one point think that was something important. I used to think, well, they came in and they had chest pain and they had a cath report from their cardiologist and it showed that there was a 95% stenosis. And I go, wow, 95% stenosis, that's important. I don't know what any of that stuff means anymore because it's not the amount of stenosis that I'm worried about. It's whether they've got unstable plaques I'm worried about. In fact, one of the really surprising things that we've learned in the past 10 years is that it's the patients with the very tight stenoses, the 80%, 90% stenoses, that are actually less likely to have the big one. It's the patients with the 40, 50, 60% stenoses that are more commonly having the unstable plaques that erode and give them the big anterior wall MI. It's really weird and very frustrating. It just sort of underscores how everything's just sort of been turned on its head in this field. And so we're trying to see in these studies how good this CT is for detecting something that's a surrogate marker on an angiogram. So it's sort of an indirect of an indirect, and it doesn't really tell me much. And the other thing that we have to mention is that the gold standard of all 3 of these papers in abstracts 1 to 3 is the coronary angiography. The coronary angiography is no gold standard, right? It's still got significant incidence of missing things. So anyway, that's number 1 to 3. Abstract 4 is an interesting little paper that compares multi-detector CT, cardiac CT with MR, and actually finds out that the multi-detector CT that they used was actually better than MR, was more sensitive. A lot of the patients, unfortunately, they weren't able to use either study or one of the studies because of a pacemaker, because of certain things that would interfere with the MR, or because of renal failure that would interfere with the angiography. But one other thing that comes out of Abstract 4 that I think is very important, and it's just a very important overall concept, and we're going to touch a little bit more on it in the second talk that I do, which will be brief, which is that the multi-detector CT appears in all these studies to overcall stenoses and lesions. And that's a bad, bad thing. Because just think about it. You've given this person a big dye load and you're doing an expensive study full of radiation, and then you're going to find something that's positive, and then what? You can't put a stent on the CT table if you need to. they need to go on and have an angiogram, a conventional angiogram, another diload, another exposure to radiation and other risks, and then only to find out that it was a false positive. Bummer. And that was a patient that was low risk. So those are some really important issues that we're going to have to face before this type of thing is ready for prime time. There have been some ED studies, and those are abstracts 5 and 6 that are fairly recent papers. I think the main point about the studies is that it's neat. You can't fault people for trying, but these are just underpowered. And, you know, they tend to sort of be similar, these papers. They're like, well, we had these patients, and we put them through our protocol, and we did our multi-detector cardiac CT, and they did fine. Great. So you got to start using this stuff, you know. But remember, it's a low-incidence disease in a low-risk population, so we can't be so quick to adopt those types of conclusions. Abstract number 7 deals with the question that you guys had about radiation, and it's about 2 times the radiation that you would get from a normal CT or from an angiogram. And in abstract number 7, they calculate the lifetime attributable risk, and they find that it's about 1 in 500 malignancies. So 1 in 500 people would get a cancer from this. And in abstract number 8, they do something that's even better, which is that they break down the lifetime attributable risk by age. If you were 20 years old, if you got one of these studies, you'd have 1 in 284 patients getting a cancer. If you were 60 years old, 1 in 466 patients getting a cancer. And if you were 80 years old, 1 in 1,338. So it's a very significant radiation dose. That's not the only problem with it. I mean, just imagine the logistics of this study. What's the commonest cause of you having to sign out a patient at the end of your shift? Mrs. Smith is waiting for CT, right? Or she's in CT, can you check the results when she gets back? Just imagine if we started doing these on a lot of patients and they have to join that queue, right? Behind the rule-out appy and behind the CT head for head trauma, that type of thing. So there would be a lot of logistics that would have to be worked out before we adopted this type of a strategy that would really impact the whole hospital's functioning. And then we did mention the diload as well. Abstract number 9 is a sort of it's an interesting analysis of all of the risks of cardiac CT versus angio. Some of the angio or some of the cardiac CT enthusiasts were a bit miffed at the portrayal of the test as having a lot of radiation risk, and some of the conventional angiographers fought back with this analysis that shows that, hey, you've got to consider some of the other risks of angiography. What are they? Stroke, dissection of the coronary arteries, hematomas, bleeding, DVT, all things that I've seen in my career, and I'm sure most of you have seen those things too. So when you consider all those risks, they say that there's still, you know, that the risk benefit, or that the favor, the balance is still in favor of the multi-detector CT approach. But again, we're not ready for prime time. Angiography is a time-tested thing that we understand. This is just a new frontier. So maybe, I don't know if there'll be any questions, and I think we're going to get back on schedule time-wise, but I think that the upshot of this is that it's interesting, and I think it's really neat because it gives us a chance to think about the disease and what exactly we're looking for. Just this technology has sort of brought us back to what is actually going on inside the coronary artery disease, and it's interesting to read about it, but we're just not ready for prime time. I think what's going to happen is that we're going to have to wait for this technology to get a little bit faster, a little bit slicker, a little bit more detailed. We just can't have 25% of the patients with studies that we can't read, that the radiologists are going to say, look, you're going to have to repeat this. We just can't have that, especially on low-risk patients that in the Canadian strategy, just to digress for a second, would probably not get anything. And here we are going down a path of risk and time and money. So I think we're going to have to wait a little longer, but I'm hopeful that over the next 5 years or so, there will be some technology that maybe will get this, you know, get it to the point where we can have that randomized controlled trial that we've been hoping for, that can show that we can eliminate a little bit more risk. Go ahead.
Could you elaborate on your comment that angiography itself isn't a real good gold standard?
The question is a good one. It's can you comment on my comment, which is angiography is really not the gold standard. Angiography is not a gold standard. There are patients that have clean angios that go on to die and have a thrombus found at autopsy. The finding, first off, the finding of a thrombus is transient. And both with pulmonary emboli and with coronary clots, patients can die of those processes, and those things can dissolve. And so you can also have an event that appears to be clearly due to a thrombus, and see it disappear on angio with your own eyes. Okay, so that can be a transient thing that you can miss. Also, angio, because it's only looking at the lumen, doesn't, sometimes you could, I've seen some really nifty demonstrations from a cardiologist doing a presentation where he showed us what seemed to be a completely clean angio, and then he showed us the ultrasound, the intraangio ultrasound pictures, and what looked like a completely narrow channel, when you looked from the outside, had this big thickened mass on the wall. But just if you were to look at, but it looked straight. It looked like a straight highway. But then on the side was this big bulge going out of an unstable plaque. And so it doesn't see outside of the lumen where some of this pathology, these sort of ticking time bomb plaques are waiting, sometimes are missed. It's a good test. I wouldn't want to say that it's not. It's an excellent test, but it's fallible. It's not perfect. Yes, sir.
I was going to say, a study is being done. It's called the CT stat study, and it's a multi-center study. It's occurring in multiple centers on the East Coast and then also at the Minneapolis Heart Institute, which is where our hospital is located. And we've already randomized over 300 patients in the last year to either a CT coronary angiogram or a stress echo. And so I think that
So the two arms of the study are a stress echo and a CT coronary angiogram? Right. And I guess they're trying to get thousands of patients, because you've already done 300. So just in case anyone didn't hear, there's a study ongoing at his facility and other facilities where they're comparing stress echo to coronary CT.
Also a question, I'm not familiar with literature that says that stenoses of 50 to 60% are more likely, the so-called soft plaque stenosis. It's not clear to me that stenoses of 50 to 60%
Are more risky than more severe stenoses. Yeah, I mean, maybe I should soften the statement a little bit to say that it's not necessarily true that a severe stenosis is more dangerous for a bad event in the next 72 hours or the next 30 days than is a less severe stenosis of 70%. And yes, there is ample data to support that statement.
Yeah, and I think exactly what you said, the correlation between calcium and unstable plaques is theoretical.
Yeah.
It's not been proved.
A lot of this stuff hasn't been proved. I mean, we don't know what the significance. If you have no calcium at all in your heart, that's a good sign. And there's an odds ratio that's less than 1 that shows that you're going to do better than other people. But you're absolutely correct that it's very hard to interpret a lot of these things to know exactly what it means. I mean, you know what? Just to even forget about the CT. Forget about the CT. You take an 80-year-old patient and you do an angio, and you show that patient has a 70% stenosis of the right coronary. Is it necessarily true that putting a drug-eluting stent in that is going to be good for that person? That's a question we don't have the answer to. There are multiple factors that might affect whether that's a good thing to do or a bad thing to do, and I don't believe that we know them.
The only thing we know for sure is 25 years from now, people will be laughing at what we're doing now.
Oh, I'm sure, yeah. Hey, listen, people are laughing at me already, so. All right, let me, so I think, do we have a break, or are we going to, I think we have another speaker. Am I stalling?